So pathophysiology, what is it basically? So it is a functional obstruction of the bowel, as we have discussed already. There is failure of motility of the narrowed aganglionic segment. The aganglionic segment basically doesn't move, it is tonically contracted, there is absent peristalsis and it fails to relax. What are the parts of the enteric nervous system that actually cause this Hirschsprung disease? So there is aberrant innervation in the form of we'll discuss in detail about the cholinergic innervation, nitrergic innervation, the interstitial cells of Cajal. Right. So first we will talk about cholinergic hyperinnervation. Cholinergic innervation of the gut causes the gut to collapse. So it becomes tonically contracted. The there is an increase in cholinergic nerve fibers seen in all cases of Hirschsprung disease. That is how we diagnose the children based upon the biopsies. So there is hyperinnervation of cholinergic fibers. They appear as thickened nerve fibers. It causes spasticity of the aganglionic segment, as we have discussed already. While doing biopsy, we use this acetylcholine esterase to diagnose an aganglionic segment. Right. Next, we move on to nitrergic innervation. So this nitrergic innervation causes the bowel to relax, to expand. So this nitrergic innervation is an important neurotransmitter for relaxation of the gut. It is identified by NADPH stains in normal ganglionic bowel, but it is absent in aganglionic bowel. See, cholinergic is there is hyperinnervation, nitrergic there is no innervation, there is absent NADPH staining, so it fails to relax. Then we will move on to the peristalsis part. It is done by interstitial cells of Cajal. They act as the pacemaker of the gut. It generates slow waves and it couples with the smooth muscles of the gut, and it helps in slow relaxation and peristalsis of the gut. They were found to be deficient or absent in some cases of Hirschsprung disease. So all the three have been implicated in the disease process. Next, we will move on to the classification of Hirschsprung disease. Like we've discussed already, it is classified based on the level of aganglionic segment, right? If we take the bowel like this, this can be taken as the cecum. This is the small ileum, the ascending, transverse, descending, sigmoid, and the rectum. So the most common presentation is rectosigmoid HT. The level of aganglionosis will be at the sigmoid colon, approximately at this level. Mid sigmoid, it can be high, mid, or low sigmoid. It is called as classical or short segment. It is seen 72 to 88% in some reports. This is the most common presentation up to sigmoid level. So what do we call it if it crosses sigmoid colon? If it crosses sigmoid anywhere between the sigmoid and splenic or transverse or anywhere here, we call it long segment Hirschsprung disease, which is the second most common, 9 to 24% in some reports. So the most common is classical Hirsch or short segment Hirsch. The next is short and long. The long is if it crosses sigmoid colon, it is called long. Even if it is in the descending colon, it is called long segment. So after that, there is total colonic aganglionosis or TCA, where the aganglionosis extends from the sigmoid, descending, transverse, ascending, cecum, and up to the terminal ileum. If it crosses the terminal ileum, last 10 centimeters of terminal ileum, we call that total colonic aganglionosis. That is, the entire colon is aganglionic. The entire colon will be completely spastic, and the small bowel will be dilated like a small bowel obstruction. So that is the third most common, and the rarest form is the ultra short HT. Ultra short HT is there is rectal aganglionation, that is up to 3 centimeters from the internal anal sphincter or 4 centimeters inside the rectum. That is below the peritoneal reflection. If it is aganglionic, we call it ultra short HT, which is very difficult to diagnose.